now we start with the chapter, everybody, that is usually not asked. Usually I am saying it is asked sometimes. So if it is asked sometimes, should we read it? Yes. We should read it because it is fun to read and because it is a very small chapter. We are talking about lacrimal apparatus. Lacrimal apparatus means how are our tears secreted. Yes. So first of all, we are going to see the secretion of the tears, the anatomy of the lacrimal apparatus, guys. Then if there is over secretion, everybody, if you are crying, basically watering, everybody, so over secretion. And if you have deficiency of tears, you have dry eye. So basically three parts: the anatomy, the over secretion, and the drying of the eyes. That is what we are going to read in this small and cute chapter, that is lacrimal apparatus. Now, first of all, let us start with the anatomy of lacrimal apparatus. Now, lacrimal apparatus, I will say I can divide it into two. Number one is the secretion of tears. And number two, everybody, drainage of tears. Okay. So let's first of all see how are our tears secreted. From where are they secreted? So obviously our tears are secreted from the lacrimal gland, we all know. We can see situated here this red color, large red color, everybody. This is our main lacrimal gland. Our main lacrimal gland is divided into two parts through levator palpebrae superioris. I am writing in short form LPS, passing through the center of the lacrimal gland. The two parts that it gets divided into, the superior part is known as the orbital part and the inferior part is known as the palpebral part of lacrimal apparatus. Important to note that the ducts, everybody, of the lacrimal gland, they start from the palpebral part. So if there is any disease or any condition which has affected the palpebral part of the gland, there will be no tear secretion. Yes. So these are my main excretory ducts. 1, 2, 3, 4, 5 that have been shown in the image. Okay. Now, the main lacrimal gland, everybody, this is responsible for reflex tear secretion. If this is responsible for reflex tear secretion, everybody, that means there must be something else, everybody, which is responsible for basal secretion. So I say along with main lacrimal glands, there are accessory lacrimal glands of Krause and Wolfring. These are situated in fornix, as we have read in the chapter conjunctiva, everybody. The place between the sclera and the palpebral conjunctiva is fornix, everybody, and they are responsible for basal secretion of your tears. Okay, everybody. So two glands, the main gland, everybody, which we all know is situated in the supratemporal part here, everybody, which is responsible for reflex tear secretion, and the accessory lacrimal glands, which are responsible for basal secretions. That's the secretion part, short and sweet, everybody. Yes. Now, how does this secretion occur? That is the question which you want to ask. So secretion occurs via parasympathetic innervation. So secretomotor function is parasympathetic, sympathetic function is inhibitory. So where is the center located, everybody? So the center starts from superior salivatory nucleus, which is situated in the pons. From here, the impulse travels via greater superficial petrosal nerve, which as all of us would know is a branch of facial nerve. Very good. From here, this preganglionic nerve will relay into the ganglion. What is the name of the ganglion, everybody? Secretomotor we are talking about, reloads into, yes, pterygocyte palatine ganglion. And finally, the postganglionic nerve, everybody. What is the postganglionic nerve? Zygomatic nerve. Zygomatic nerve is a branch of maxillary nerve. And maxillary nerve is itself a branch of trigeminal nerve. Okay? I hope you understand. Very simple anatomy, everybody. Yes. So zygomatic nerve will finally supply my lacrimal main gland and will lead to secretion. That is the parasympathetic pathway for secretomotor function from the lacrimal gland, everybody. So preganglionic nerve, everybody, please remember, is the greater superficial petrosal nerve. Then the name of the ganglion is pterygopalatine ganglion, and then the postganglionic nerve is zygomatic nerve. Okay, everybody, and that's how we secrete it. Once the tears have been secreted, now there needs to be drainage. If there is no drainage, everybody, there will be over secretion, over watering, everybody. So let us see through the image again. What is the pathway for drainage, everybody? Okay. So drainage of tears. Now drainage of tears starts from this point, everybody. What is this point, everybody? This is the puncta. This is the puncta. There is a puncta in the upper eyelid. There is a puncta in the lower eyelid. If you don't know a puncta, if you've never seen a puncta, everybody see this image. In this image, where my arrow is marked, can you see in the lower lid a small hole, everybody? This is the puncta. This is the start of your drainage. There has to be a hole for water to go in, everybody. Yes or no, everybody? Now, from the puncta, the fluid or the tears go into the canaliculi. So the second part is the canaliculi. Just like the lower and upper puncta, which I am writing L and U, there is lower canaliculi and upper canaliculi. So this will be my lower canaliculi, this will be my upper canaliculi. Then everybody, finally the fluid, the tears go here, everybody. What is this, everybody? The main part where our tears collect, known as lacrimal sac. Okay, lacrimal sac is surrounded by, everybody, circularly by orbicularis oculi muscle. So somewhere when you blink, everybody, your tears drain because it is covered by orbicularis oculi muscle, everybody. Okay, so I'm writing for you, surrounded by orbicularis oculi. When we blink, everybody, the lacrimal sac, because of orbicularis oculi, everybody, it is compressed, it leads to drainage of fluid, everybody, downwards. Then there is positive pressure created which sucks in fluid from the puncta. Basic science. From the lacrimal sac, the fluid will flow here, everybody. What is this now, everybody? This is called the nasolacrimal duct, NLD. Now we all know through our ENTs, I hope, that the NLD opens in inferior meatus of nose. NLD opens in the inferior meatus of nose, guarded by valve of Hassner. Yes or no? So if we see our pathway, what does it become, everybody? Starts with puncta, goes into canaliculi, from canaliculi into lacrimal sac, from lacrimal sac into NLD, and from NLD into the inferior meatus of nose, which is guarded by the valve of Hassner. Valve of Hassner is important because, as you will read further on, everybody, in cases of congenital dacryocystitis, the most common site of blockage is at the valve of Hassner. Okay, everybody, and that's your simple and short lacrimal apparatus, everybody. How is the secretion done? What is the parasympathetic part? And how is the drainage of tears done? Now that we know about the anatomy, everybody, we will be discussing about the watering eye. What leads to the watering and how to test for watering of the eye.
Once we know this, we will say that there is some problem in the drainage which is leading to watering. Now, watering of the eye can be said to have two terminologies. Some places you will see written hyperlacrimation, and you will also see another word associated with watering eye, that is epiphora. So are hyperlacrimation and epiphora the same thing? Yes, in both the cases we are saying that the eye is watering out. But what is the difference? Epiphora is due to blockage. Blockage somewhere in the drainage system. Okay? But hyperlacrimation is when watering is due to emotional stress. Basically what your normal crying is, everybody. Or if it is due to any ocular inflammation. Like we must have noted that watering is a symptom of corneal ulcer, of uveitis, and a lot of other diseases. Am I clear to everybody? So in those cases we call it hyperlacrimation, but if there is blockage we call it epiphora. So what we need to know is how to be able to find out, how to be able to test, investigate for hyperlacrimation or epiphora. If it is a blockage, where is the blockage? Yes, that's what we are reading now, investigation or testing, everybody. Testing of watering eye. Testing of watering eye is done via syringing, probing, and Jones dye test. Syringing and probing use the following instruments. So what are the instruments? Let's see. The first instrument A. This is called as needle ship punctum dilator. So the puncta, we are making it larger to be able to do the test. Okay. Then the second instrument, this is called as the Bowman's lacrimal probe. And third, you can see this. This is a 26 gauge bent needle cannula. So using these three instruments, we are doing syringing, probing, and then Jones dye test. So let's see the whole procedure, everybody. First of all, what is done? Obviously, puncta is dilated. The instrument you have already seen. Then the 26 gauge needle, blunt tipped obviously, is inserted into the puncta and canaliculi. Saline is injected. Now, after saline is injected, there can be two types of patients. First patient, which says that the fluid is flowing into nose and throat. So the patient will be able to taste a saline taste in the throat now, from the inferior meatus into the throat, everybody. In this case, we will say there is no blockage. Or we will say the patent drainage system. Okay. So if there is no blockage, what can be the causes? Thus, I can have three causes of the watering of the eye. It can be hypersecretion. I'm writing an H. The second cause can be lacrimal pump failure, LPF. These are the short forms I will use. Or there can be partial obstruction, PO. Okay, everybody? So if the drainage system is patent, you can have three differential diagnoses. We will see how to differentiate between them a little later on. Let's move on to the second case. The second case is when the patient says that there is no fluid coming into the throat and instead you see regurgitation of fluid. You see what everybody? Regurgitation of fluid. That you inject it from the lower puncta, it comes back out from the lower puncta or from the upper puncta. Regurg. Okay? If there is regurgitation of fluid, everybody, there is obstruction. Or I can say blockage. If there is obstruction or blockage, then you need to move on to doing what, everybody? Probing. Okay? Probing will be done using that small thin instrument, everybody. I will show it to you again. This instrument, which is called as the Bowman's lacrimal probe. This is inserted again into the puncta, then into the canaliculi. Okay? We are probing it. On probing, we can have two cases. We can encounter a hard stop, or we can encounter a soft stop. Hard stop or soft stop. What do you mean by this? When we are taking a thin wire-like instrument, everybody, if there is a blockage, that instrument will strike the blockage. Now the feeling can either be something that you are touching a soft thing or a hard thing. If you are touching a hard thing, think about it, everybody. You must have gone through the puncta, through the canaliculi, through the lacrimal sac, and then now you must be poking onto the lacrimal bone. A bone is giving you a hard stop. That means there is no obstruction in the canaliculi or the lacrimal sac. That means the obstruction must be in what, everybody? Nasolacrimal duct. Am I clear about this, everybody? But if you encounter a soft stop, that means there is an obstruction somewhere either in the canaliculi or in the lacrimal sac. So, lacrimal sac or canaliculi block. Am I absolutely clear about this? No confusion, I hope, everybody. Done? That's your one part done. If there is an obstruction, where is the obstruction you want to know, and that can be known through probing. Now let's move back to the first scenario, where we have either had hypersecretion or lacrimal pump failure or partial obstruction. These cases are differentiated by Jones dye test. Jones dye test number 1. There are two Jones dye tests, number 1, number 2. What is Jones dye test number 1, everybody? We are injecting 2% fluorescein dye into conjunctival sac. Okay, so just put 2 or 3 drops of 2% fluorescein dye in the conjunctival sac. Then place a cotton at opening of NLD in the nose. Okay, so you have to take a cotton bud, everybody. Cotton, or I'm saying bud here, and place it at the opening of the nasolacrimal duct. What are you trying to see? You are trying to see whether, everybody, the cotton bud gets soaked with dye, or I can say fluorescein stain. In such a case, I will say Jones dye test 1 is positive, and the case will be diagnosed as hypersecretion. Okay? That means there was no obstruction, nothing at all. It was just a simple case of hypersecretion. That is why the dye was able to travel throughout my lacrimal drainage passage. Secondly, everybody, if no staining of bud by the dye, that means the dye has not been able to travel up to the ending of NLD. We say Jones dye test 1 is negative. Okay, everybody? So if Jones dye test 1 is negative, then we perform Jones dye test number 2. What is Jones dye test number 2, everybody? Residual fluorescein. that is still somewhere in my pathway, everybody. Residual fluorescein is washed out by irrigation. Okay? So now you are injecting fluid again with pressure so that whatever fluorescein was there with pressure tries to get washed out and your bud stains now. Okay? Again, I can have two cases. Now the bud stains. If the bud stains, now I will say Jones dye test 2 is positive. If Jones dye test 2 is positive, then the answer is partial obstruction of nasolacrimal duct. Partial obstruction, PO everybody, partial obstruction, but of nasolacrimal duct. So the obstruction was partial and thus with pressure, when we tried to wash away the fluorescein dye, we were able to stain our bud, but not otherwise. Second case, everybody. Again, there is no staining. Bud does not stain. That means still the dye has not been able to wash out. That would indicate that Jones dye test 2 is absolutely negative. If it is negative, I can have two answers, everybody. Either lacrimal pump failure, LPF, I am writing short form, or partial obstruction of upper parts. That means the canaliculi basically. Okay? So the dye was not able to travel at all into the lacrimal sac. So there was no pumping action at all. It was remaining in the canaliculi. We can have two things here. Then, how to differentiate between lacrimal pump failure and partial obstruction? To differentiate, do dacryocystography. Now you have to ultimately resort to imaging basically. Am I crystal clear about this? So to differentiate, we do DCG, dacryocystography. Done, everybody? So I know it sounds a little complicated the first time. Let's just see it again, everybody, from the top. It will be very easy. First of all, what we are doing, everybody, we are trying to push in the fluid, everybody. If the fluid does not go into the throat, if it regurgitates, everybody, there is obstruction. If there is obstruction, hard stop NLD blockage, soft stop lacrimal or canalicular blockage. But if the patient has fluid in the throat, everybody, it can either be hypersecretion, lacrimal pump failure, or partial obstruction. If there is hypersecretion, you do Jones dye test 1. The dye will travel into the bud, everybody. So we are saying Jones dye test 1 will be positive. I'm just writing here. If it is lacrimal pump failure, Jones dye test 1 will be negative. Also, Jones dye test 2 will be negative. Now the last most complicated case, partial obstruction. Here Jones dye test 1 will always be negative. That's the only surety. 2 can be positive or negative based on partial obstruction of NLD or partial obstruction of canaliculi. As we have seen, Jones dye test 2 is positive on NLD obstruction and negative in cases of canalicular obstruction. Am I clear, everybody? Just try to remember this. Just try to think about it once. You will be able to get a hang of it. No confusion at all. That is how you evaluate the causes of a watering eye, everybody. Done? Now, when we have talked about lacrimal sac, if we don't study dacryocystitis, the simple pathology, it is always incomplete. Dacryocystitis basically means inflammation of lacrimal sac. Now, if there is inflammation, we divide it into two parts. One is congenital and the other obviously is adult or acquired. Okay? Congenital dacryocystitis, as the name suggests, will be present since birth. So usually what the complaints are? Complaints of watering since birth. The mother will say the eyes of the infant are watering since birth. Yes? The cause here is non-canalization of nasolacrimal duct. Non-canalization of nasolacrimal duct with the occlusion most commonly at valve of Hassner. Am I clear? So the site of obstruction is actually the opening into the inferior meatus of nose. Now, if such is the case, what is the treatment? Number one, please remember the most basic treatment is lacrimal sac massage. See, when we are trying to do massage, what we are asking the parents to do, slightly with a very little force, press the lacrimal sac and then move the finger down. Everybody look at me. Press the lacrimal sac, move the finger down. Press the lacrimal sac, move the finger down. We are trying to push the fluid so that by this force, the blockage opens out. Am I clear? Along with that, obviously, topical antibiotics needs to be administered, usually azithromycin or tobramycin. Okay, everybody? So that superadded infection does not occur due to the collected water. Secondly, if 9 to 12 months, if the age of the child or the infant is now 9 to 12 months and the occlusion has still not opened, then you will push the fluid down with your syringe like we do in the investigation, syringing. Thirdly, everybody, if greater than 1 year of age and still the obstruction hasn't opened, then you will take in the Bowman's lacrimal probe and you will try to open everybody the obstruction. You are just opening the obstruction, yes? And lastly, everybody, if greater than 4 years, then you do DCR. Dacryocystorhinostomy. As already explained, we break the lacrimal bone to form a contact straight away between the lacrimal sac and the middle meatus of the nose for the drainage of the tears. Done, everybody? So this is a graded treatment based on the age. Now let's move on to adult, everybody. Adult cases are usually caused by Streptococcus hemolyticus. Okay, everybody, that is the most common bacteria that is causing this inflammation. Now, what is the treatment here, everybody? First of all, obviously you have to give antibiotics, usually oral antibiotics, okay? And you have to do DCR if fistula has formed. So if a fistula has formed and there is pus collection, you are seeing a swelling over the medial part, everybody, that is when you have to opt for an DCR. Am I clear? Very simple topic, everybody. Dacryocystitis, please remember congenital mainly. Those are the parents that are worried and it can be treated very easily. Done. Now let's see the tumors of the lacrimal gland, everybody. There are two tumors of the lacrimal gland. The first, you have come across the word, I am hoping, pleomorphic adenoma. This is a benign tumor. The second is adenoid cystic carcinoma. This is a malignant tumor. So both types of questions are asked. What is the most common benign pathology or malignant pathology? The two answers are given. Whatever be the case, everybody. Where is my lacrimal gland situated? My lacrimal gland is situated supratemporally. So when there is a tumor, it will push the globe where, everybody? First of all, it will push it down and then it will push it in. Am I clear to everybody? So you will see that the eye is pushed down and medially. That is how you get to know that this is a lacrimal gland tumor. Am I clear? Very simple, fundamental, nothing difficult. I hope you understand this. That's all about my lacrimal apparatus, its simple pathologies and the watering of eye. Now moving on to the last topic, everybody, dry eye. For that, what we want to study? We want to study what is a tear film, first of all. Once we know the tear film, we will be able to understand dry eye. So tear film, everybody. If this is my cornea, limbus sclera. First of all, on the cornea, you will see epithelium has microvilli. Okay? Corneal epithelium has microvilli for the attachment of the tear film. Then tear film has 3 layers, everybody. The first layer is the innermost layer. Second layer is simply called the middle layer. And then The third layer, outermost layer. This is the tear film layers. The innermost layer, everybody, is formed by mucin. Mucin, chipkega, mucus. You understand, everybody? Mucin. So we want adhesion property onto the cornea. Yes? Mucin, as we must have noted in conjunctiva, is secreted by goblet cells. Secondly, everybody, middle layer. Middle layer is formed by aqueous, pani, secreted by lacrimal glands. And then, everybody, outermost layer is formed by lipids. Why lipids, everybody? Aqueous, pani will evaporate, aqueous will evaporate, water will evaporate. So we want to stop the evaporation, everybody. So to stop the evaporation, there has to be oil over water, everybody. Yes, oil means lipids, everybody. So lipids, they will prevent the evaporation, and they are secreted by meibomian gland. So I hope we understand now how the tear film is formed, what is the specific function of each of the layers. Mucin is giving adhesion, aqueous is giving wettability, gilapan, and lipid is preventing the evaporation, and where they are secreted from. Yes? If we know this, everybody, then we can understand that dry eye can be of three types. The first, I am saying aqueous deficiency. Cases of aqueous deficiency are called as keratoconjunctivitis sicca, KCS. Okay. Then there can be lipid deficiency. And lastly, there can be mucin deficiency. Three layers, three deficiencies. Aqueous deficiency, if I give you an example, the usual cause is Sjogren syndrome. Okay? Then lipid deficiency is known as evaporative dry eye. I hope you understand why, guys. Because if the lipids are deficient, the aqueous will evaporate. The examples for this are meibomian gland disease. I hope you understand why. So if meibomian glands are not able to secrete the lipid, obviously there will be evaporative dry eye. Or if there is contact lens wear. Usually these are the two cases. Mucin deficiency. I'll just give you one example, everybody. This is usually seen in vitamin A deficiency. Okay, conjunctival xerosis, corneal xerosis. Am I clear, everybody? No confusion about this? Done? Now, once we know this simple classification, what is the more important point? How to be able to diagnose the case of dry eye. Yes? So how to diagnose? What are the tests, everybody? Number one, test for dry eye. The first test that we are doing is Schirmer test. This is a quantitative test. Quantitative test basically means it is measuring the tear production. It is giving us a number. Okay, guys? It uses Wortmann's filter paper number 41. So this strip that you see, this is Wortmann's filter paper number 41, guys. You can see that the width is 5 mm and the length is 35 mm. How do we do this test? You see this blue line, everybody? You see this blue mark or this blue line, everybody? This is where this strip is folded. Okay? This fold is then inserted into the lower fornix, everybody. We take like this, we insert this, and then it will hang here. Then you will wait for 5 minutes. After 5 minutes, you will see how much of this strip has become wet. Okay, so let's say this much of the strip has become wet, 20 mm. Okay, so we know that there is no dry eye. Greater than 50 mm wet strip means normal. But if it is less than 10 mm, then we know it is dry eye. Am I clear to everybody? No confusion. So simple quantitative test, that is Shermer's test based on the strips that you can see in the image. Done? Now, the second test that we can do is known as TBUT. Tear film break-up time. Tear film break-up time. Let's understand what is this, everybody. 2% fluorescein is instilled in conjunctival sac. Illuminated with blue light. I hope everywhere that we have mentioned fluorescent dye, we have always mentioned blue light, everybody. Whether it was in cornea, staining for corneal ulcer, or whether it was in Goldman's applanation tonometry, okay? Everywhere we have to illuminate with blue light. Now, after this, everybody, what do we notice, everybody? We notice the interval between a blink. When you blink, it will spread the tear film all throughout, yes? And appearance of the first spot of dryness on cornea. Wherever the cornea will dry, everybody, you will not be able to see the fluorescent dye there. Am I clear to everybody? You understand how it's working? So I will blink, it will spread, and then a dry spot will appear. So I'm noticing the time between the blink and the dry spot. If less than 10 seconds, then I have mucin deficiency. But if it is dry spot always at same location, then corneal disease. That indicates some kind of underlying corneal disease, because every time that same place is becoming dry. Am I absolutely clear? No confusion about this? So TBUT is basically diagnosing specifically the cases of mucin deficiency. Then the third test that we can do is known as phenol red thread test. Phenol red thread test. Even though the name is red thread test, in the photograph you will see it's a yellow thread hanging from the eye. Why is that so? Let's see, everybody. So we use a thread impregnated with phenol red dye. When we impregnate it with phenol red dye, it is yellow in color. On contact with tears, it becomes red in color. Am I clear, everybody? So it is called the phenol red thread test because it will become red in color when it comes in contact with the tears. So what do, everybody? We see after 15 seconds. What is the length of the thread that has become red? So let's say in this case, this much has become red. I will measure this length, everybody. Okay? If less than 6 mm, then I have dry eye. But if greater than 15 mm, it is normal. Okay? If you are wondering in all the tests, what about 6 and 15 between them? So see, there is no clear-cut answer. Yes, these are borderline areas. We have seen this in Shermer's case also, less than 10, greater than 15. Yes. So there are some gray areas where you are supposedly thinking about dry eye, but you cannot diagnose it with surety, everybody. Am I clear? So please remember all these values in all these tests. There are a lot of other things you can do, but these are the commonly done tests for diagnosis of dry eye. If you ask me, sir, what is the treatment for dry eye, everybody? If there is aqueous deficiency, you will have to give lubricants. If there is lipid deficiency, you have to prescribe omega-3 fatty acids. And there can be various other treatments depending on the cause. If it is a Sjogren syndrome, everybody, then you have to give a cyclosporin. So there can be various things, but let's keep it simple. Let's understand how to diagnose. Treatment, you can think about yourself. Am I clear to everybody? That's all about dry eye. That's all about the simple topic lacrimal apparatus. Please understand again, first of all, the anatomy, then the watering of the eye, and then basically tear film and the test for dry eye. Right, guys? That's it about lacrimal apparatus.